Many clinical trials use time-to-event endpoints, for example, the time to disease progression or overall survival. However, interpretation of the outcomes of these trials can be challenging. For example, time-to-event trials can often end before all patients experience the event of interest. Because of this, basing the mean time to event on the trial data will underestimate the true mean. An unbiased mean can only be calculated if all patients have experienced the event. For this reason, in a clinical analysis, such as a license application, for example, the median time to event may be presented. This can be estimated as long as 50% of the patients are no longer at risk for the event. It is not appropriate to apply a median value from a clinical study to the population of an economic evaluation, because important information about the sample is not captured. A mean value should be used if patients do not all experience the event of interest in a clinical trial. Statistical techniques are often employed to estimate the true mean time to event for economic evaluation, rather than using an underestimate derived from a trial. Take time to event data on a Kaplan-Meier graph, for example. Here, the probability of patients to not experience the event of interest is plotted against time. This is known as a survival curve, although it can be used for any time to event data, not just time to death. The area under the survival curve represents the mean time to the event, and the median is where 50% are no longer at risk for the event. In a trial that ends before all patients have experienced the event of interest, a complete survival curve cannot be drawn and the trial mean underestimates the true mean. To address this, modeling can be used to estimate the complete survival curve. A model must be selected according to two main criteria. It should fit the observed data well, and the extrapolation beyond the observed period should be credible. One option to check this can be real-world data supplemented with expert opinion. This extrapolation allows the true mean to be estimated by calculating the area under the modeled curve. Economic modeling of long-term endpoints from short-term outcomes can mean that small treatment differences appear much larger when extrapolated. In most treatment areas, differences in the benefits of treatments, both in terms of costs and effects, are often minor. Additionally, in clinical trials, effects tend to be measured over a short time period. This has implications for the certainty of the results. For example, for a clinical trial, measuring survival over 3 months may demonstrate treatment A to have slightly more benefit than treatment B. When we project these results long-term, based on what has been observed, the treatment difference may appear to be much greater. If the results from the original trial were uncertain, we risk diverging away from what might actually happen later down the line. When there is a small initial difference between the treatments and minimal observed data, the larger the uncertainty will be in the future. These issues have consequences for economic evaluations. For example, the robustness of analyses results may be reduced, which might impact reimbursement decision-making. The challenges in assessing time-to-event endpoints can be exacerbated by trials where patients are permitted to switch between treatments over the course of a trial. Reasons for this will be discussed shortly. For example, if patients are allowed to switch treatment following disease progression, then it can be difficult to provide evidence of the impact of the assigned treatment on overall survival. This is because treatment switching has occurred prior to the relevant event, in the case of overall survival, death. This means any estimate of a treatment effect on overall survival may be inaccurate, and potentially underestimated. While these issues may be addressed by prohibiting treatment switching in the clinical trial design, this may be considered unethical for reasons discussed shortly. It might also reduce the incentive for companies to collect longer-term survival data and keep patients on their allocated treatment post-progression. Reasons for treatment switching. Randomized controlled trials, RCTs, are widely used to measure the effects of an active treatment compared to a control for a particular patient population. The outcomes for each treatment arm are then compared, usually at the end of the trial. In oncology trials, survival outcomes are commonly used, such as death or disease progression. However, patients may switch from the treatment to which they are initially randomized, which can cause challenges in analyzing the outcome data. Patients usually switch from the control group to the active treatment arm. However, they can also switch to a non-trial treatment or to no treatment altogether. So why might patients within a clinical trial switch treatments? A clinician may decide that a patient is responding poorly to their allocated treatment, and it is therefore unethical to let them continue on this regimen. In oncology trials, patients are often allowed to switch to the new therapy at the point of disease progression. Patients may experience treatment-related side effects of their allocated treatment. The alternative treatment has demonstrated positive results during the trial, even before long-term endpoints are followed up. The alternative treatment may already be available on the market for other reasons. A treatment may already be indicated for late breast cancer, but is not currently licensed for early disease. In this case, clinical trial patients with early-stage breast cancer who progress to a later stage of disease are permitted to switch to a treatment indicated for late-stage breast cancer. Since prohibiting treatment switching is unethical, statistical methods are often used to overcome the issues caused by treatment switching, although there is no clear consensus on which method should be employed. There are naive and sophisticated approaches. Intent to treat, ITT, analysis continues to follow a patient from the control arm, who has switched as if they have not, despite them receiving the other treatment. Exclude or censor all patients who switch. Sophisticated approaches. Rank-preserving structural failure time models, RPSFTM. Inverse probability of censoring weights, IPCW. Naive approaches are often biased, and may not accurately reflect the true effect of a treatment. For example, ITT analysis is likely to underestimate the benefit of a treatment. More sophisticated statistical methods can be used to overcome the impact of treatment switching, however, due to their complexity, they will not be discussed here. In general, there is no clear consensus on how to handle treatment switching in the analysis of results, and the method used may not apply in every situation. A clinical judgment to assess the assumptions which should be made is required. For example, is the treatment effect likely to continue or diminish? If the latter, an early treatment effect measured during a clinical trial cannot be assumed to be the same in the long run. In this video we have covered how time to event and survival data are used and the issues associated with analysis of these data, as well as how these issues can be exacerbated by trials where patients are permitted to switch between treatments. We also looked at methods employed to overcome these implications. We also covered what treatment switching is, and why it occurs in RCTs, including poor treatment response, disease progression, treatment-related events, proven efficacy of alternative treatment, or the treatment is already on the market for other reasons.